Okay, welcome back. This is probably a short talk, and we'll look into the anatomy of the knee. So it's a very important weight-bearing joint, and most of the pathologies are related around the knee joint. So we look at the patella. The knee joint comprises of the patella, that's the anterior compartment, and that's the facet where the retinaculum we discussed in the earlier, that the vastus, rectus femoris, along with medialis, vastus medialis and lateralis, they join in and they form a retinaculum, and tendon attaches here, forms a sheath around this, and it goes down and forms the inferior patella retinaculum, and it attaches just the superior margin of the tibial tuberosity. The important thing is just why I want to show this. Basically, for you are able to identify, define and localize the abnormality when you see on spect CT. So you need to put in your report the exact anatomy of a bone. So you're looking at patella. So the patella is the external, and the internal is the cartilaginous, which articulates with the trochlear of the femur. So it should be within the intercondylar groove, and it should sit on that because the intercondylar groove of the femur has got a cartilage. So it should be cartilage to cartilage where the synovial attachment goes. So you're looking at the fibular head. So that's the lateral part. So this is the medial, which is slightly protuberant. So you've got the medial epicondyle, and that's the condyle. So condyle and epicondyle, and then it comes into the articular surface, and then you go into the lateral condyle and lateral epicondyle. That's the adductor tubercle and forms the adductor canal, and the adductor muscles passes through and attaches. We're going into the tibia. You've got the condyle here, lateral condyle, medial condyle. These are the plateaus. So when you are talking of abnormality here, you talk about the tibial plateau. There is either depression or there is degenerative changes or fracture. Then you talk about the medial or lateral plateau. If there is some pathology related to this margin, then you talk about the condyles. That's the tibial tuberosity. This is the crest. So you know these are the two plateaus, these are the two condyles. So you can either say intercondylar ridges or crest. This is lateral, so this could be lateral crest, and this is medial, this could be medial crest. Very simple, isn't it? So I think that is basic of anatomy of the knee. I don't want to go into these grooves, popliteus and all that. You don't need to know that. So that's the lateral projection. So you look at the cortex, again very smooth, very well outlined. You follow it. You see this, the patellofemoral joint, patellofemoral space. That's the margin. It's slightly oblique, so that's why you see one face of the patella, and that's the posterior face of the patella. That's the anterior, and that's the cartilage. And you see irregularity if you do arthroscope. If you put in an arthroscope, visualize this, you see some irregularity and fibrillation. So this may reflect degeneration, early degeneration. And if you start seeing changes along the bone, then you've got early arthritis. So this is the most common place where you get anterior knee pain, and you need to identify so that you can correct that rather than patient having total knee. The other thing is you need to look at the suprapatellar fat space. So if there is any injury, any inflammation, you lose this and you get fluid-filled space, and that is suprapatellar pouch effusion. So looking at again the lateral projection, the articular cartilage of the condyles. I don't want to go into detail, we have already talked about. So AP, again looking at this. So you've got fibular head, and then you've got the neck and the articulation between the tibiofibular joint. So there is nothing different, similar. Again, if you look at the joint here, as we talked about the joints, you've got two joints, two articular cartilages from one bone to the other bone. So you look at the cortex and look at the regularity and homogeneity. So basically, if you see a disruption in either side, then probably you are thinking of either degeneration or osteochondral defect, or it can be a fracture. So this is what I was saying. You have got vastus, rectus femoris, medialis, vastus medialis, lateralis, and this forms a reticulum, and this forms these superior patella tendon, and this is infrapatellar tendon, and this basically is attached to the tibial tuberosity. You can avulsion injury involving the superior pole of the patella. You can have avulsion. Normally it doesn't evolve from here, it evolves from the tibial tuberosity. So if you've got avulsion, you'll see some bruising over the tibial tuberosity, and that will reflect intrapatellar tendon avulsion injury. You have bursa again. You've got a muscle. Underneath that, you've got femur coming down. So just the space there, that's the patella. So just superior to the patella is a suprapatellar bursa. There are different and multiple bursae around the patella. So it could be supra, it could be inside, so it can be infra. And then you have got prepatellar bursa. This gets inflamed mostly in people who do work, especially on the floor, and they are always on their knees. Because of chronic irritation, they can have inflammation, and then that can cause bursitis. This is infra, so you've got infra patellar bursa. Then you have got the gastrocnemius arising from there, and semitendinosus. So you have got bursa there. The lateral head of the gastrocnemius arising from the lateral side, you have got a bursa which expands and becomes popliteal bursa, and that can basically be major cause of the pain in the popliteal fossa, which is posteriorly, and it causes inflammation and can rupture into the calf muscles. Gopi showed you one scan, so any volunteers, what is this? Is this a fracture? So the difference between a patella fracture and bipartite patella, as I told you, if you have got, you look at the margins, you look at the cortex, very well defined, very well cortically outlined, so it's less likely to be a fracture. In bipartite patella, it is usually by two fragments and usually involving the lateral side. If you look at the medial side, then it's not bipartite, it's most likely fracture. So this is just, you need to remember. So lateral side, and you see the well corticated areas, so that's bipartite. So this is very common abnormality seen on bone scans. Uptake in the patella, what it is, and how you're going to. So the prevalence is about 2% of the population. Superlateral accessory ossification center of the patella is usually present by 12 years of age and may persist into adult life. So again, another example. When you're looking at the bone scan and when you're going to report the knee, you need to be aware, and I've learned with time and with discussion, that if you see diffuse uptake, then you don't need to be bothered about of reporting, because normally that's what you see. But as said, it can be arthritis, but nobody's going to intervene. But if you see focal uptake, that is very important, and especially when you're doing a spect CT, then you need to report that, because that could be the pain generator. So it is very important. The pattern recognition is important in all nuclear medicine. You need to identify what your patterns are and how you're going to interpret them. So with patella, to my understanding, to my knowledge, if you see a diffuse uptake, it is less likely to be pathological. It may be associated with degeneration, but no necessarily there will be any intervention. But if you see focal uptake, then that could be because either there is lateral migration or there is abnormality because of continuous trauma, because of malalignment and maltracking. So that needs to be addressed, and the surgeons will take that seriously. And this one is, yeah, that's avulsion. So avulsion of what? Here or here? Yeah. So now this is very, sorry? Yeah. So it's basically taken, and you've seen this is effusion. So you've lost planes and you've got effusion there. You can diagnose on plain film. What is this? Yeah, OCD. So that's the lucency, that's the bone, so that's a fragment. Again, so these are the common abnormalities you see, and especially in bone scan when you see focal uptake, don't just discount it and say it's just nothing else other than arthritis. So this is commonly you see, and that is commonly the cause of the pain. And this basically needs intervention, and either they rest and give painkillers, otherwise they need to put a scope in and then take this fragment off. What's that? I've written it there. So now if you go back and look at what I said about the femur, these are thread-line dense trabeculae. So it's involving the whole marrow and probably destroying. So normally it doesn't destroy the articular surface. It's within the marrow and it becomes infarct. People with sickle cell and steroids are prone, and probably chronic renal failures. So this is a typical picture. If you see this, and if you see abnormal uptake on bone scan, Gopi showed it last presentations, and the pattern and distribution is likely to be infarct. Yes. It's basically, it's not a single vessel which has been involved, so it's multi-vessel. So this patient, I don't know the history background, but either the patient is on steroids, it affects the whole system, or chronic renal failure. So, but chronic renal failure, I can't see any findings on the plain film. So in chronic renal failure, you will see calcification running along the vessels, which I don't see it. So this patient probably has not got any steroids because there is no osteopenia. So either the patient is sickle. So sickle, you can have this typical appearance in the metaphyseal region of the proximal joints in periarticular region. I don't know the history. So again, this is again infarcts, bone infarcts here and here. So how will you describe? You will describe this. This is where it is. So you have got at both distal ends and the proximal end of the bones. So these are the metaphyseal, diaphyseal junction. So this is the diaphysis. This is the expanded part is the metaphyseal. So at the junction here and at the junction here, the metaphysis is fine. So you have got it at this junction. Somebody was asking me yesterday about the uptake in the last scan. So basically, if you see this, you see these thread-like projections coming out, and it's basically involving extending to the other cortex. So how you will define there is heterogeneity with areas of trabecular thickening, showing increased density, And if you're looking at the bone scan, you'll see with increased uptake, and it's at the margin of, or at metadiaphyseal junction of the distal end of the tibia, of the femur, and proximal end of the tibia. So the history will be there, so in keeping with or is diagnostic of bone infarct. You need to, if you're looking at the CT, then you need to tell them that whether, because the other thing which you can see, but you're seeing at both sides, but if you see something similar on this side, NOF is the most common. Either you see it in long bones in the femur or in the tibia distally, and you see exactly the same pattern, and that is non-ossifying fibroma. Very characteristic on plain film, and it can be hot on bone scan, and infarcts can be hot on bone scan, so it may mimic. But if you have got multifocality, then infarcts are most likely, with the history predating it to whatever management or treatment they have had. What is this? Which is exostosis. And what's that? Yeah, so that's very, so it's enchondroma, and this is exostosis, and these are multiple. You've got one here and one there, and maybe, so this may have got a syndrome, so, or this could be an exostosis because of the projection, so it's all lying. So if you do a lateral, you may see an excrescence coming out. So that's why you say in imaging it's very important that you do two projection. Even in nuclear medicine, you're seeing something AP, you say, okay, let's look at the ribs from the lateral, and even in the head, skull, you see AP, you don't know where the lesion is, you cannot localize it. So you do a lateral, you say, oh, this is in the posterior or the sphenoid rather than nasal.